Hello, 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 everyone. Welcome to another episode of Indiaspora Community Conversations. This is a monthly program with Sree's Global COVID-19 show. My name is Sree Sreenivasan. It's my honor to convene this monthly conversation around various aspects of the pandemic. Today, we have a especially terrific show, and you'll meet our guests as we talk about the medical, health, and scientific advances and developments with regard to COVID-19. Thanks everybody so much for being here. We truly, truly appreciate it. Hi folks, I'm Sree. I'm the Marshall Loeb Visiting Professor of Digital Innovation at Stony Brook School of Journalism and the co-founder of Digimentors, a social, digital, and virtual events consulting company. We do this show every month with Indiaspora in order to connect with their amazing network and to highlight and spotlight their amazing members and friends. So today we are especially excited to be joined by Dr. Sejal Hathi, who's here with us. And I will tell you a little bit about her. She's a resident physician at Mass General Hospital and the host and creator of Civic RX. She's an Indiaspora board member, and she has both an MD and an MBA. And we are just absolutely delighted that she's here as our host for the show today. Hi, Doc.
Hey, Sree, great to see you.
Thank you for being here. How are you doing on this day as we celebrate International Women's Day, Women's History Month, etc.?
Yes, I am thrilled to be here, and I'm even more excited that we have an incredible cast of women leaders across healthcare and truly from every domain within healthcare, that of practicing clinicians to entrepreneurs and to health policy wonks and administrators. Really a full cast of women who can paint a nuanced and thoughtful picture for us about what the last now 12 months has meant and what the future indeed for this field might look like. So I'm excited to be here. I'm a little tired, to be honest, and just coming off a long day at work, but really grateful to partake in and moderate this conversation.
Thank you. We are so grateful to you and all the doctors and nurses and healthcare workers this past year, done amazing work to keep us all safe. We are super grateful to all of them. All right, let's tell you about our guests as we bring them on. Dr. Sulata Dwarkanath is with us, founder and CEO of Kaya 17. Dr. Nilima Ragavan is with us, a clinical professor of pediatrics and neonatal perinatal medicine at Stanford Medicine. Meena Seshamani is also with us. Dr. Seshamani is vice president of the clinical care transformation at MedStar Health. And Priya Singh, chief strategy officer and senior associate dean at Stanford Medicine. So great to have everybody here. Folks, please tell us where you're watching from. Please tag your friends. They can watch live or later. We're live on Facebook, on Twitter, on YouTube, and on LinkedIn. So with that, let's say hello to this fantastic team of folks who've joined us. Hi, everybody.
Hi there.
Hi.
Hello.
All right, Dr. Hathi, over to you.
Thanks, Sree. So I thought we would get started by allowing each of you to introduce yourselves and the incredible work that you're doing. So Sue, why don't we get started with you, and then we'll head to Nilima, Priya, and Meena.
Thank you, Sejal. It's an honor to be here with all the all-star cast that we have today and talking about the very relevant time for COVID-19. My company, Kaya 17, we have developed a rapid 15-minute on-the-spot COVID-19 test. It's an antigen test that can be done very quickly and gives very accurate results in 15 minutes. And I'll talk more about what we're doing and how we're doing it as we go along.
Great, thank you. Nilima?
Yeah, so I'm a clinician, an educator, and as the medical director of one of Stanford Special Care Nursery, an administrator, and also a mentor for junior faculty. And much of our work, of course, as clinicians has continued throughout the pandemic. I'm currently actually on a 2-month professional development leave, kind of like a mini sabbatical. Was supposed to have been in India doing some global health work, but of course, all travel plans are on hold. But I'm actually doing a very exciting project right now in collaboration with the government of Gujarat to create this series of monthly webinars on neonatal medicine with expert Stanford faculty and with Gujarat faculty also collaborating. So really excited about that.
Yeah, thank you for sharing your time with us today, and I'm grateful that you're still able to do some of the global health work you had anticipated. Meena?
Sure. So I'm Meena Seshamani. I am a practicing physician, an ear, nose, and throat surgeon, and also a health economist and a health policy expert. And at MedStar Health, I lead our efforts to be able to better integrate care across the care continuum. You know, how we can provide more person-centered care that really addresses the needs of people and their communities. And that has become even more important through the pandemic and through COVID-19. So our efforts around community health, addressing chronic conditions, care at the end of life, both for frail elders and palliative care. And I look forward to discussing more of that to come.
Absolutely, thank you. And last but not least, Priya.
Thanks very much. Priya Singh, I lead strategy for Stanford Medicine. It's wonderful to be on today with all of you very accomplished women, some of whom I'd never met before, others I do know a little bit. In my role at Stanford, as I mentioned, I lead strategy, and we were fortunate enough just about a year and a half ago to have launched the first sort of integrated strategic plan for Stanford Medicine, and we're wonderfully focused on sort of bringing together all parts of our tripartite mission: education, research, and clinical care. And then, of course, you know, when the pandemic hit us, things changed a little bit, and the execution and wonderful plans around our strategy have been partially on hold, to be quite honest, a little bit, while we've been consumed with all things COVID, as I'm sure everyone can imagine, and has been to some degree everyone's experience in healthcare. But most recently, I'd say I'm most immersed in all things vaccine delivery, and it was supposed to very much be, and it is for the most part. I'm an optimist, and I do believe it is the light at the end of the tunnel. But unfortunately, we've had all kinds of hiccups in the rollout of the vaccine, certainly here in California and in the Bay Area. And so that's just made things a little bit more, what's the right word? I'd say chaotic than we had hoped for. So still optimistic about where things are headed, but not still feeling the tough times, I guess, to some degree.
Yeah, no, that makes a lot of sense. I wonder if, and Priya, you alluded to this in your response, but I wonder if each of you could speak to maybe a silver lining of the pandemic for you personally and for your organization, whether it's a new insight, a new program that you've engendered, a new perspective on your work, and perhaps any newfound priorities. What gift, if you will, have the last 12 months enabled for each of you?
I'm happy to jump in. And I'm a little bit more sort of strategy and business focused. You know, the others, many of you are actually physicians and much more immersed in healthcare. For me, it's been all about the people. It's been about getting closer to my team at work. We've spent more hours together than than we ever expected to. We know each other more now than we've ever known each other before. And on some level, more time again than we never imagined or expected with our immediate families. And so that's been the silver lining, I think, is just getting closer to the people that one might have already somewhat been close to, and really making that a priority. I think prioritization has been critical during these times, just really understanding and recognizing what's most important.
Yeah.
I can go. Go ahead, Nilima.
Oh, okay, yeah. I was going to say that a silver lining for me personally is to not have to negotiate parking at Stanford. So I think that's been the fringe benefit of all of the Zoom calls and meetings, that I don't spend all this time trying to, find parking in all of the construction that is always going around Stanford. But no, on another note, I would say that I was concerned about all of sort of the Zoom meetings. In fact, our very first division meeting that went on a Zoom platform rather than an in-person meeting, I was making a presentation, and I was really concerned that I would not be heard because there wouldn't be all these people in person. Well, we had the largest audience ever at that meeting. So I think that what this has allowed is for actually more people to interact, just like Priya was saying. And on a broader level, as a physician who is very concerned about climate change, I have to say that I hope that the decrease in travel has led to a decrease in the carbon footprint that we're leaving behind. So I would say that that's another silver lining.
So from my perspective, I think those of us in healthcare have known that there are many things that need to be improved about the system, from, reducing the fragmentation, really focusing on the whole person, considering, how social needs and health-related social needs and equity play a role in the care that people experience and the health that they feel. And the pandemic really brought all of those to light. And, for some of us, enabled us to really innovate on that. Among my teams, that we took our 5-year strategic plan and implemented it in 5 weeks because, we really needed to rise to the occasion and establish, better integration of clinical and social needs, given the incredible disparities that are being experienced by people with COVID-19. Being able to leverage telehealth to be able to improve access to care and to provide a more multidisciplinary approach, and being able to partner across community-based organizations, our skilled nursing facilities, to really create that network of support for people and their communities. And those are all things that not only enabled us and have enabled us to help and care for people during the pandemic, but that will leave us in a better place as we move beyond the pandemic to where healthcare goes to.
Mm-hmm. So from my perspective, I'm coming from the industry perspective. So, like all of you said, things had to be moved very fast. So we did the same thing. We were focused on, since ours is a platform technology, we were focused on doing allergy testing. So, infectious diseases was the second level priority for us at that time. But when COVID started, that changed the whole prioritization of how we strategize in the company. And that really made the silver lining for us, because we could develop a test, which would usually take about a year and a half to develop one test. We did that in like 4 weeks, 6 weeks, and we had it out there. So that really brought a lot of people together, a lot of different things that are needed to get to that point together. And that made the whole difference. And, having said that, there was a lot of struggles getting to that point too, because of COVID, because everything was online, and being able to work in the lab, there's nothing online you can do. You have to be in the lab, you have to get things, even to buy something, it was a real big problem because nobody would want to come and deliver stuff. So we had to, innovate and improvise on things that we had, and work with like things that were not available, but you could, improvise on what you had and go forward. So it's been an interesting experience, both in terms of having a silver lining and having to struggle through it. But in the end, we now have a great product that can be used. And that makes me feel really good, because something that we could come up so quickly and is so useful in the situation we are in now, that makes a huge difference for me.
Yeah, so let's actually talk about that. Sue, your company has developed a new rapid coronavirus diagnostic test, and we've heard a lot about testing in this country, about the need for more testing, about the absence until recently of a national testing strategy. We've also heard of the plethora of different types of COVID tests that are available and are being developed. I think that there is still significant misinformation and misunderstanding about how these tests work and which tests perhaps are most apt for which settings and which also are accurate. So I thought maybe you could help elucidate some of these questions for us by telling us, what type of test exactly have you developed? What is a rapid test? Is that different from a PCR test? Which one is better?
That's a very good question, Sejal. This has been, like you said, a lot of misinformation and a lot of difference of opinion that has been given. So there are two types of tests that you can think of. There's the molecular test, which is the PCR test. Everybody knows about it now. It's RT-PCR test. Then there are the antigen tests. Both have merits and demerits for themselves. RT-PCR tests are very accurate, but take a longer time to do the test. The turnaround time for these tests are very quickly done, would be like a day or two. And I've seen like these days it's come down to 2 days. And maybe if you fast track it, you get it in 24 hours. The antigen tests are it can be done very quickly. They're rapid tests. In antigen tests, you have 2-3 different types. There are these what are called the strip tests, which are like the pregnancy tests. They can give you answers only for certain types of diseases. For a virus or a bacterial testing, that's not the best one to go after. And so in the beginning, market was flooded with these kind of strip tests. And you could see that gave a bad rap to the antigen test because they were so inaccurate. It was useless doing those tests. Then came the set of tests that were more accurate in the antigen area. And we are in that realm of things. We have a very accurate antigen-based rapid test. And why rapid is so important in this situation, as you all know, that for example, take for airlines, they say that you have to test 2 days before, and then you take your report, and then you can fly. Now, within the 2 days, what has this person done? Where did they go? Did they get infected in those 2 days? We don't know. Whereas if you have a rapid test, you can do it in 15 minutes, right in the airport or in any place, for workplace, wherever it is, right? And schools and other places. And you can do it every day if it's cost effective. And then you can enter the airport and things like that. So this is the difference between a rapid test and then, a PCR test. And they are trying to make PCR also rapid, but you can only do so much with that. Now, how did we get so accurate, right? Okay, there's always, there is a consensus out there that antigen tests are not accurate. And how did we get so accurate? We did a lot of innovation in electronics, in material sciences, in reagents and various things. And all this came together in one place. And that is our big invention in this realm of things. Now, so we have shown and we have validated our test. We have shown that it's 98% accurate in our clinical studies. We have applied for EUA approval. We're waiting. I don't know why we are waiting for so long, but we are waiting because it's needed right now. But we are approved in Europe. We have a European certification, so we're starting to sell outside the US. But I wish we could start selling it here soon.
And why do you think the EUS or emergency use authorization from the FDA has taken as long as it has? Are other companies like your own struggling? Is the US regulatory apparatus too slothful? Is that problematic? What's going on?
Yeah, the FDA is known to be very slow, and if anybody has ever worked with FDA, you know that they're not that fast. Having said that, they have this emergency use authorization where they do fast track approvals. I think what happened, maybe this is my guess with FDA, that initially, like I said, they did have approval for a lot of these antigen tests, which were very inaccurate. Maybe now they're very scared to approve other things. I don't know. But this is a wild west at this point. But I hope FDA picks up the pace and starts doing it because, contact tracing, making sure things are happening, you need this rapid test. And they keep saying they need rapid tests, they need point of care tests. And we have one. We have one that is good. And we still are waiting for the approval.
Hi, folks. Sree here, just checking in for everybody who's just tuned in. This is our monthly show with Indiaspora, our community conversations, and we have a fantastic conversation going on with medical doctors, scientists, and folks who are helping us understand where we are with the vaccine, with the testing, and just generally the outlook on the 1-year anniversary, as we know, of America at least shutting down. And we have folks watching from all over the world. We want to just give a quick shout out to our friends. Jonathan Borstein is watching from the East Village. Hi, Jonathan. Stefan Kaplan's watching from Ramsey, New Jersey. Manuel Linares is watching from Spain. Hello. And Apollo is watching from Montclair, and he has a question. The question is, how can the testing keep up when we have governors like Abbott in Texas, who has lifted the mask mandate and the more virulent UK COVID strain is in wide circulation in Texas? So who would like to tackle that?
Well, lifting the mask mandate and testing are two different things. I hope they still continue to test even though the mask is lifted, right? But it would be good to have both together. And I think the best way to control is to keep the mask on and keep testing, because that's your only bet at this time, unless you have the vaccine, which we also don't know the long-term efficacies of the vaccine, which is to be looked at right now.
And Apollo has another question about vaccines, keeping up with all the new strains. So where are we with that, and how worried should we be about that?
Well, I would jump in and say, and I should be the last one to jump in since we have a bunch of physicians on the call, but I work with our epidemiologists every day, and I would say that they feel fairly confident that the vaccines actually will allow for many of these new strains. But again, I should let others weigh in.
No, I think that's right. I think, and they're continuing to do studies, not only on the efficacy of the vaccines with the variants, but also looking at how vaccination affects transmission and, other things as well. So I think the data will continue to come out.
Yeah.
Terrific. Thank you, folks. And please keep the questions coming. Tell us where you're watching from, and please post your questions for these terrific guests that we have. We're going to hand this back to Sejal Hathi. Dr. Hathi has a fantastic podcast of hers, which is called civic-rx.org. And her former guests have included Dr. Anthony Fauci and Dr. Celine Gounder, who many of you know, of course. So please do check out civic-rx.org. Sejal, back to you.
Thanks, Sree. Priya, I thought we could pivot to you and talk about some of the work that you're doing at Stanford. And I'm particularly interested in maybe some of the innovation happening around telehealth. COVID-19 has been said to have ushered forth a veritable telehealth revolution, as almost instantaneously health systems capable of this shift transition the majority of their clinical care visits online. And I think, correct me if I'm wrong, but Stanford, to my knowledge, last spring oversaw a leap in virtual visits from 2% of their total to over 70%. Is this a blip, or is this merely the first step to the full virtualization of care? What is your take on remote care models, everything from telehealth to at-home diagnostics to remote monitoring? And what is Stanford doing now, if anything, to capitalize on this trend?
Yeah, thanks, Sejal. I think it's exciting times, and some of what we saw as dramatic shifts, I think to some degree at least, are here to stay. And I think your numbers are close, maybe a little bit different than my numbers, and I'll share some of those. I think we went from pre-COVID roughly about maybe between 2,000 and 3,000 virtual visits a month to over 3,000 a day. Rapidly. And frankly, I want to say the quarter before we were hit with the pandemic, we must have done about 3% of our visits roughly in telehealth. And then we were up, I think 70% is a bit of a stretch, but we were up to, closer to 60. So you weren't too far off. And I'd say where we are now is, sort of in the, 50-ish%, even today. And I think there's something to be said for finding the right balance, particularly for a place like Stanford Medicine, where, there's a lot of complex care and things that aren't best suited even at times like this to virtual care. And so I'd say that where we'd like to land is about in the 40 to 50%-ish ultimately. And I think we'll stay there and get there. What's been most interesting, at least from my perspective, has been, and again, I'm sure some of the physicians can speak to this a lot more than I can, but it's been interesting to see fields that would otherwise not have really considered telehealth or virtual visits really improvising, innovating, and finding new ways to provide virtual care. I mean, neurology is a perfect example. We had our department chair and many other leading faculty members participating heavily in virtual visits in the type of care that otherwise, like I said, they probably wouldn't have considered at all. On-demand urgent care is another sort of area that we're exploring. And I think all of these are things that we might have moved towards more gradually before, but have rapidly moved in the right direction and are likely to stay there, I would say.
Yeah, this conversation about telehealth actually makes me recall that there were certain primary care practices, and I'm thinking of my own as well, but there were certain primary care practices last year that found it much easier, in certain health systems that found it much easier to rapidly shift to telemedicine models than others. And I think those practices that had adopted value-based models over fee-for-service or volume-based models were among those that were able to adapt more readily to the changing demands that the COVID-19 pandemic posed. And I wonder, Meena, you've done a lot of research and work on this topic, both in the Obama administration and then more recently in your current role at MedStar. Can you talk to us about how COVID-19 really revealed and underscored the need for value-based payment and delivery reforms? And what are some of the changes that you think we need to think about, policy changes to accelerate progress in this realm?
Sure. So for those who may not, understand the terms of like value-based care or fee-for-service, traditionally healthcare has been paid for, where somebody comes in for an office visit, for a hospitalization, there are payments that are associated with those particular things, and then the patient kind of goes on their way. So when you look at COVID-19, you can take wonderful care of a COVID patient in the hospital, get them better, and then send them on their way, where they tend to be lower income, tend to be from vulnerable communities. And oh, by the way, now they have to isolate for 2 weeks. And do they have 2 weeks of food in their fridge, in their freezer? And do they have a housing situation where they can effectively isolate? It really brought to light a lot of the issues that exist when you look at care in these very siloed and fragmented episodes. And it really encourages us to think about care instead as a continuum, where you are thinking about the patient and what that person needs. And this is where this value-based care or alternative payment models come in, where you are rewarding care that provides for better health, better outcomes, spending money in a smarter way, where you are engaging in prevention and paying for health care as opposed to just sick care. And so to that end, where investments even before the pandemic had been made in things like community health workers or, patient educators and navigators, you're able to leverage those to really address these issues with the pandemic that came about. So for example, for us, we have been able to utilize our community health workers to not only proactively support communities in preventing the spread of COVID, but then if someone develops COVID, if they come to our hospital, being able to work with that person, with their family, with their community, to make sure that when they're discharged, that not only are their healthcare needs met, being able to set up follow-up appointments for them, checking in on them, making sure they're doing okay, but also their social needs. Do they have the medications they need? Do they have food? Do they need food? What is their housing situation? And so that's an example of where you can provide care in a different way, and where health systems have been able to be agile to do that with the pandemic. And that creates that pathway to do more of that in the future.
That's incredibly interesting. I wonder, Priya, at Stanford, are there other programs or interventions that you've additionally implemented to really target these social determinants of healthcare? We've, I think, seen acutely over the last several months, or keenly rather, how much health is contingent on the socioeconomic context of a patient. It's not merely about their clinical presentation in the hospital, their physical disease, but rather the legacy of structural inequalities that they and their communities have long borne. Are there things, Meena talked a little bit about some of the things we're doing with community health workers at MedStar. Are there similar programs that Stanford has piloted or is scaling to address some of these social determinants?
Yeah, there are lots and lots of programs. In fact, there wouldn't be sort of one comprehensive way to cover all the amazing work that's being done by all of our faculty, very much in this space. I will mention it's been interesting to hear what Meena said, and even your question, Sejal. Our Dean Minor, often talks about how difficult it is to see that health outcomes are more affected by a person's zip code than a person's genetic code. And that really speaks volumes, I think, about the state of healthcare in our country and to some degree globally as well. We recently established a commission on justice and equity, and we're taking a deep look at ourselves and our own health system, and it's intentionally a commission of world-renowned leaders in the IDHE space that we've brought to the commission, but intentionally also we've included several members of our own organization from all layers of leadership and employment at Stanford Medicine. So it's intentionally a very diverse group of people who serve in a variety of healthcare roles. And the idea really is to take a broader and bigger look at asserting ourselves in a national role to address health disparities. We have a wonderful vision and mission around precision health. It touches a little bit on what Meena just mentioned. It's sort of differentiated from precision medicine in that we're far more focused on prediction and prevention than we are on curing disease. And underneath that broad precision health mission and vision, we have a series of programs that many of our faculty are engaged in. Not enough time to go into all of those right now, but yeah, lots of work being done here, and a long way to go, frankly.
Yeah, no, I agree with you. I think this is just the beginning of the conversation, and I hope even as we begin to recover from COVID, I hope that we will continue to center the experiences and the realities of vulnerable communities across this country. Mm-hmm. Speaking of health disparities, I think that there has been significant debate over the last few months, particularly about vaccine distribution and ensuring that underserved and high-risk communities are appropriately prioritized in that allocation. Meena, I know in Maryland, a recent analysis, I think I read about it in the Washington Post, uncovered that with the exception of Baltimore, rural counties, largely Republican counties, receive nearly twice as many vaccine doses per capita as urban areas where more minority communities are centered. I know that at MedStar, you've sought to respond to the challenge of equitable vaccine distribution in a few ways by meeting people where they are. Can you tell us how maybe you at MedStar and more broadly in partnership with other cities and organizations across the state are working to center equity in vaccine allocation?
Absolutely. It comes back to, one of the themes that we started this conversation with about the importance of partnership and thinking about health beyond the four walls of any one particular stakeholder, but really thinking about it in a more holistic approach. And so at MedStar, we have partnered with many community-based organizations. This is even before the pandemic. We had been working on a mobile health clinic for some of the underserved communities in Baltimore. And so when that mobile clinic went live, lo and behold, it was very successful with flu vaccinations because you're going out to those communities, not only in terms of just physically going out to those communities, but having community health workers from those very communities be the ones to reach out to people, explain what this is all about, answer questions, support them through the process of registering to get a vaccine. And so we said, okay, when there is a COVID vaccine, because at that point there wasn't, so when there is a COVID vaccine, we're going to have to leverage this because there are lessons to be learned here about how you can really reach people where they are. So with the city of Baltimore and with some of the other health systems in the area, we are utilizing our mobile health clinic to go to some of the most vulnerable populations in inner city Baltimore. And it's really been amazing. The work of our team, the work of the nurses and the community health workers, both bringing people into the van for vaccination and also working with the communities to set up vaccination clinics like in their conference rooms, in their community. We have a more than 2/3 acceptance rate of the vaccine with these communities. And it's really remarkable also just in terms of, again, with the theme of what does the pandemic teach you and what are foundations that you're building through this, being able to have these kinds of partnerships across multiple types of organizations, immigrant organizations, African-American faith-based organizations. I mean, these are things that are powerful, not just for addressing this pandemic, but moving forward to how do we actually improve the health of our populations and how do we address equity?
So, Meena, I have a question for you. You mentioned you have been going in the mobile vans and dispensing the vaccine. How has the availability of vaccine for you guys? I mean, I've been hearing all these different things that, oh, I didn't get enough shipment, and there was a lot of other issues. And Priya even mentioned about the logistics and other things. How is that experience for you?
Yeah, absolutely. I mean, the supply issues are kind of known. Hopefully they are improving, right? I mean, they definitely have been improving, and I think will continue to improve, especially because we now also have a third vaccine that is available. The logistics are very interesting. I mean, with the Pfizer vaccine and the ultra cold chain, storage that's required, that definitely limits our ability to use it in a mobile way. I will say that for our home-based primary care program that treats frail elders, for example, in the home, we have figured out how to deliver the Pfizer vaccine, to the home for these patients. And it literally includes like figuring out, okay, once the vial is open, like how does this physician transport it in the car from one place to another and make sure that the vial doesn't shake that much? There definitely are logistics issues. For the mobile clinic in Baltimore, we are using the Moderna vaccine because that one doesn't have as many logistics around the storage. And I anticipate that this will be an ongoing effort as we get other vaccines and you determine what works, what doesn't. I think one of the keys here is this continuous learning. I mean, nobody has experienced this pandemic before, and the last pandemic was before vaccines. So this is all new that we all need to just roll up our sleeves and learn together as we go along.
Yeah.
So I just quickly add, super quickly, that for us, we're actually in a particularly tough spot this week, and we expect it's going to look like that in the San Francisco Bay Area for the next couple of weeks, only because we've shifted from getting our vaccine supplies from the county now to being to getting supplies from the state. And during that transition, just in terms of systems and various distribution methods, it's been spotty, and our supplies are very limited, and we've had to even cancel a series of appointments, naturally frustrating a lot of people who were getting ready to get vaccinated, and were told that their appointments had to be postponed sort of for at least a few more weeks. So tricky times. We're hoping that in the next couple of weeks things will get a lot better, but it's been tough.
Nilima, we're chatting a lot about vaccines, and I'm sure you fielded numerous questions from new parents-to-be, about the safety of vaccines for themselves, and particularly for pregnant women and eventually kids. Can you share with us some of the advice that you're maybe granting to your patients and their families?
Yeah, absolutely. So as you know, pregnant women and children and babies were excluded in the vaccine trials. So the reality is that we really do not have information in terms of long-term effects of the vaccines. However, having said that, even with the vaccine trials, there were people who were vaccinated in those trials who then were pregnant. And so there is some information that is now available. We also, as you know, have information about vaccines that have been given during pregnancy. That includes, of course, the most common being the influenza vaccine. So as long as it's a non-live viral vaccine, and then other vaccines that are used also, such as tetanus, for example, that have been given to pregnant women. So with all of the evidence that we have right now, and knowing, as we know now, that pregnant women can actually have more serious consequences if they develop COVID-19. In the early months of the pandemic, it was felt that perhaps they were not getting sicker, But now we do know that there are more serious consequences for pregnant women if they do get COVID-19. With that knowledge and with the knowledge that we have about vaccines, the recommendation would be for pregnant women to also get vaccinated. Now, ACOG, which is the American College of Obstetricians and Gynecologists, recommends that pregnant women have a conversation with their healthcare providers. So pregnant women who do fall in the risk categories that are currently being vaccinated should certainly discuss that and be vaccinated. Similarly, there are a lot of pregnant women in the healthcare field, and I know many of them have received the vaccines. And again, we're getting more and more information about these. There's a registry that is also now started. So all in all, my overall recommendation right now is that if you balance the risks of COVID-19 on the pregnant mother and on her unborn child, and then on the neonate after she delivers, and you balance that risk with the theoretical risk of a problem with vaccination, I think the balance is in favor of getting vaccinated. So that's what I would say.
Thank you so much. Just great to have all of these comments and questions coming through as well. And Paul Suri says that while the concept of virtual teleconsulting, telehealth is great, he says that it doesn't work on all health issues, and he didn't have a good experience. So can you talk a little bit about that for folks who are feeling that something's lost during telemedicine? Who would like to tackle that?
Well, I'll just say very quickly, it was sort of, I agree with the point being made. I mean, this is why you might remember that I briefly said we went up practically to over close to 60% of our visits being virtual, and we don't want to stay there, much as that's a number that's impressive on some levels. We recognize that there are certain conditions and certain areas in healthcare that aren't best suited to virtual care. And so we're being very conscious about, yes, during COVID, we had to innovate, and we're glad we did. And there were certain fields which took rather quickly to virtual care where they wouldn't have considered it before. But we're dialing back from that now and making a much more conscious effort to look at where is it most effective and where is it really not appropriate, and really pulling back to finding that right balance. So I hope that's helpful on some level.
It is. I'd like to ask Dr. Hathi a question. You, as someone who is on the front lines yourself, you're in the hospital setting. What are the lessons that you have learned this year?
Sure. So I think that's a loaded question. I've learned a lot. I think first and foremost, it's just how creative we can be when the urgency is high. The number of new programs that have been introduced in the hospital in the last several months has been truly extraordinary. I'll tell you about one that I actually created in the early months of the pandemic with a fellow nurse at the hospital. We noticed, as so many others did across the country, that patients, in the wake of new visitor policies, barring anyone from joining them in the hospital, were spending many of their days alone. And that meant for COVID-19 patients that they were often spending their final hours alone. And no one should have to suffer those final hours of their life without someone by their side. And no family wanted to be without their patients or to not have someone by their loved one's side. And so we created a program that placed volunteers, clinical volunteers in rotations at the patient's bedside to just be present with them in those final hours. And, eventually hospitals started using iPads and Zoom and FaceTime were applied so that families could see one another in those crucial moments. And that all happened because of the pandemic. And I think that there are so many people that came together across specialties, across administration and frontline worker to make sure that our patients were being best served, and also that those of us on the front lines did not have too heavy a burden to carry. It's been truly heartening to be a part of. And I just wish that we were able to carry forward that same spirit into all of our work, even beyond this pandemic.
Thank you. And what a great answer. Really nice to hear that. Lotte is watching from Bhutan and says, thank you for all this useful information and great work. Lotte watches on a regular basis and says, Bridge to Bhutan offers bespoke tours once you're ready to locate your Zen. So I think a trip to Bhutan sounds wonderful, or a trip to India or wherever else folks are going. We'd love to, as we wrap up here, we'd love to see if there are any more questions that come in, but otherwise, as we wrap up here, I'll just ask if each of our guests could give us kind of final thought as you look ahead, and any signs of both, where are things working? How do you know that everything's on track? And how do you know if there are things that we have to be careful about, and what should we watch for? So I'd love each of our guests to answer that, and then we'll wrap up there. So Priya, do you want to get us started?
Yeah, I'll just say a little bit again of what I said at the very start, which is, in spite of all of what we've talked about in terms of stumbling blocks, whether it's about testing, and by the way, the decline in testing is a little bit worrying, given that we haven't reached everybody with the vaccine yet. But I still feel very, very optimistic with the vaccines and how strong their performance has been coming out, and supplies increasing, that there's just very much light at the end of this tunnel, and everyone should feel energized about what the fall and coming winter are likely to look like. And then also, I think we've got to go back and really take a hard look at the lessons learned, just what we've learned about human behavior, what we've learned about leadership in a crisis. There's some absolutely wonderful learnings that we need to study and examine, and hopefully apply some of the best sort of practices to hopefully not another pandemic, but other crises that are likely to come our way in the future.
Well, thank you very much. Priya Singh has been our guest, Chief Strategy Officer and Senior Associate Dean at Stanford Medicine. Thank you very much. Let's go to Meena.
Great. So, piggybacking off of that, I think another theme has been, what, with the lessons learned from the pandemic, and what can we take moving forward? And with that, it's thinking outside of the box sometimes. So to pick up on what both Priya and Sejal have spoken about with telehealth, telehealth is not necessarily just about, taking a physician talking to a patient in an office and instead making it virtual. It's also about leveraging telehealth so that families can participate in care when they're unable to visit the hospital. It's also about being able to extend the capacity and reach of a multidisciplinary team in a health system. So really being able to take this as an opportunity to continue to think creatively. And the other point that I don't think has been raised that I think is worth noting is wellness. And the issues around, again, this is picking up on something that Sejal had said with the burdens that the providers have felt, really making note of issues of wellness among not only frontline healthcare workers, but also essential workers, and honestly everyone. And we've seen that the rates of overdose have gone up. Opiates was an issue even before the pandemic, but making sure that we're continuing to address the other aspects of health and well-being as we move through the pandemic.
Thank you very much. Meena Seshamani is a Vice President and Clinical Care Transformation at MedStar Health. Dr. Seshamani, thank you very much for being with us. Let's go to Nilima.
Yeah, thank you. So I would also like to add to this theme of the mental health impact of the pandemic, and particularly in my area, in the perinatal field. As you know, the birth of a baby is usually a joyous time, a time of celebration with extended family, and none of that was possible due to travel restrictions. But for some of our families, and especially the parents of the sickest and most vulnerable babies that we take care of in the neonatal intensive care unit, this is also a time of great stress. And I speak not just as a neonatologist practicing for several decades now, but also as a parent of a baby who was in the neonatal intensive care unit. This is probably one of the most stressful times that one has to go through. And what the pandemic has done is that during this most critical time when you need the support of your loved ones the most, you're sort of left without that extended support of family and friends. And in the earlier days of the pandemic, as we were sort of negotiating, different guidelines for visitation and so on, it also meant that sometimes our parents were also left sort of without the support of the spouse due to visiting limitations. Thankfully, we sort of quickly corrected that. So I think that this, mental health impact will, continue on even as, vaccine rollout improves. The second point that I wanted to make was that, as new problems such as, this COVID-19 pandemic arise, all problems do not go away. And in fact, some of the disparities that existed in my field, such as the higher rate of preterm birth among certain populations and in women of color, these have only been exacerbated with the pandemic. And so it's almost like we are going to have to work, doubly hard now in the years to come to sort of make up for this, reversal of some of the improvements that had been made in this arena. So just wanted to remind people that those old problems are still there and they still need to be solved.
Thank you so much. Dr. Nilima Ragavan is clinical professor of pediatrics and neonatal perinatal medicine at Stanford Medicine. Thank you very much, Doctor. And now let's go to Sue.
Yeah, Sree, this pandemic has changed a lot of different things that people, how people thought about things. And, it has brought about some, new changes and new thinking with people. And that I have seen in my company and outside my company. In fact, a lot of people, when we started, like I said before, we had a lot of issues with supplies. We had a lot of issues with what we could use to develop this test. And people, I saw people come up with like these new ideas, new ways of doing things. We don't need that resource. Don't worry about it. We'll just make do with what we have. We'll make the best out of it. And that really showed the spirit of people, how we could overcome this, and not in just inside the company. This is in their lives too. And strangers came to me and said, "Hey, how can I help? Because I want to do something for this pandemic. How can I help? Can I do something in your company? Can I do something else?" People I knew, people I didn't know did this, and I think this is very important lesson for us going forward. You don't need too many resources to do things. You could do it with less resources. And I think as a country, we do use that going forward. I think it makes a huge difference for who we are and who we can be.
Thank you very much. Sulata Dwarkanath is founder and CEO of Kaya 17. Thank you very much. And before we go to the Sejal, I just wanted to show everyone this tweet that I saw today that kind of captures how a lot of us feel. This person said, in 2020, the pandemic is coming. You got to stay inside. This person says, oh no. And now 2021, the pandemic ending. And as you got to go outside, this person says, oh no. And it kind of captures how many people are feeling. So Sejal, over to you for some final thoughts.
Thank you, Sree. So I really just want to reiterate a few of the points that my fellow panelists have shared, which is, namely, I think it's critical over the next several months that we invest more significantly in mental health and in enhancing the well-being both of our frontline healthcare providers and our essential workers and America more broadly. I think for the last 12 months now, we've borne witness to the unsparing ravages of a pandemic that has plundered now over 500,000 lives, millions of jobs, countless milestones, pure normalcy. And we truly are on the brink of, if not already in the throes of, a secondary mental health pandemic. A disproportionately high percentage of Americans are reporting depression, anxiety, malaise. And that's only going to continue to get worse. Meanwhile, if other pandemics and data from other countries are any indication, healthcare workers are likely to bear the burden of PTSD and other trauma from everything that we have suffered for many, many more months. And so it's imperative that we bring mental health out of the shadows. We've long stigmatized it. We've long underfunded it. And now is the time to reverse course. So I hope that we continue to talk about what we're each going through. I think Megan and Harry's interview a couple days ago was a boon in that respect, and that we also put our money where our mouth is, and hopefully we'll see that from this new administration in DC as well.
Thank you. Sejal Hathi is a resident physician at Mass General and host and creator of Civic RX and an Indiaspora board member. And tell us who you have coming up on upcoming podcast episodes.
Oh, yeah, sure. So to our friend from Bhutan, I also want to offer my commendation. I just aired an episode with the Minister of Health of Bhutan, Dechin Wangmo, last week, and we discussed how Bhutan has been an unlikely pandemic success story, sustaining just one death over these last 12 months from the pandemic, as compared with the debacle that has ensued in many of its Western and wealthier counterparts. Mm-hmm. But I had a really enjoyable conversation with Dechin, and actually tomorrow morning we're releasing an episode with President Jonathan Nez, the president of the Navajo Nation, to just discuss the plight that their people have suffered, I think, at the hands of a long legacy of policy failures of the U.S. government. So that's, and then the following week, we'll be discussing COVAX and vaccine equity across the globe.
Sure. So everyone, please check out Civic RX. We'll just read you a couple of other comments. Here's a hashtag wellness and healthcare. And Dr. Anisha Abraham says, great discussion on the ongoing COVID response. Thank you for this insightful discussion. Jonathan Borstein says, fascinating and important program. Thank you. And Dr. Abraham says, in the field of pediatrics and adolescent medicine, we have seen an enormous increase in mental health issues, eating disorders, obesity, also missed vaccinations. We are worried about having a lost generation of children. There's so much that needs to be done. So she's talking, of course, about the regular vaccinations that young people get. Apollo says, yes, Dr. Hathi, mental health and treatment and coping skills strategies are critical going forward. And Feroz says, as the vaccines only reduce the probability of infection and not eliminate it, it makes sense to keep adhering to precautions as much as anyone can. And Lotte says, you shared your story. Thanks for sharing your story. Look forward to the conversation. So with that, I want to thank everyone for being here. Thank you to our friends at Indiaspora. Thank you to this awesome all-star panel. I learned a lot, and I know our audience did as well. Everyone, please check out the incredible work of Indiaspora. Check out the website, Twitter, Facebook, and the Instagram channel. And we're so grateful to be able to do this every month. Thanks very much, everybody. Bye-bye.
Thank
Bye.
you.